The Effective Mood Management After Stroke program is collaboration between the Departments of Rehabilitation Medicine and Psychological Medicine, Tan Tock Seng Hospital. The Ministry of Health funds the program under the Mental Health Blueprint. The program aims to use validated scales to screen for depression in this cohort. In this case, the screening tool is the Modified Patient Health Questionnaire or PHQ-2. The PHQ-2 is sensitive but not specific, and therefore a diagnostic tool is necessary. Therefore, PHQ-2 positive patients will be administered the structure clinical interview for DSM diagnosis or SID. Based on the above screening and diagnostic tools, appropriate recommendations will be made for the treatment of depression in this cohort. The program has undergone 3 phases. For the first phase, from December 2008 to June 2009, the team collected baseline data from the cohort. This was important to help guide the implementation of the program. For the second phase, from July 2009 and January 2010, the team validated the PHQ-2 and PHQ-9 in the post-stroke patients. For the third phase, from February 2010 to present, we have implemented the program. All patients admitted to TTSH rehab for stroke and whose abbreviated mental test is 6 or more will be enrolled into the program. They will be screened for depression with a PHQ-2 at time 0, which is the second day of admission. Patients will be screened again at time 1, which is at the point of discharge, and at time 2, which is 3 to 4 months from admission. Screened of depression with a PHQ-2 is done by the medical officers at time 0 and time 1, that is when patients are inpatients. Note that the time to assessment is done as an outpatient. These are the details of the screening process. At time 0, those screened negative by the PHQ-2 will be screened again at time 1, and if the screen is again negative, they will be screened again at time 2. Patients screened PHQ-2 positive at time 0 and time 1 will be referred to the psychologist for assessment with a SID. Those patients not diagnosed with depression will be screened again subsequently. Those who are diagnosed with depression based on the SID will be treated appropriately. As at time 2, as the screen is done as an outpatient, the treatant physician will be informed if patients are screened PHQ-2 positive. The physician will make a clinical assessment for depression and treat the patient accordingly. This may include starting medication, a referral to the psychologist or psychiatrist. Based on the validation of the PHQ-2 and PHQ-9, it was shown 46.6% of patients had significant depressive symptoms if we took the PHQ-9 score of 5 or more. With a cutoff score of 10 or more on the PHQ-9, 22.1% had significant depressive symptoms. As for diagnosis based on the SID, 11.4% had a diagnosable mood disorder, 8.8% having an adjustment disorder, while 2.6% had major depressive disorder. Symptoms most endorsed by a depressed group of patients include depressed mood, sleep problems and fatigue. Risk factors for depression include the absences of a spouse and living alone. It was also found that the Functional Independence Measurement or FIM scores of patients with depressive symptoms were significantly lower than patients without depressive symptoms. Also, the Quality of Life scores of patients with depressive symptoms were significantly lower than patients without depressive symptoms. It was also found that at admission, there was a significant difference in the depression severity for the treated and untreated groups. After the implementation of the program, at discharge, there was no significant difference in the depression severity for the treated versus the untreated group. Also, of those diagnosed with a mood disorder, 58% received antidepressant medication, 64.5% were seen by the psychologist, while a psychiatrist saw 16.1%.